thank you all for coming today. The focus of my talk today in talking to Scott and working out a topic was really to look at where myeloma is at, and thankfully we have a new horizon and where we are at with treatment, and when we talk to patients and family about the outlook and prognosis when that person or a family member is diagnosed, thanks to a lot of new advances, particularly in the last 16 years or so. And those advances are only accelerating. The focus in terms of the descriptions is a mix of going back to basics and then getting to some fairly highly scientific stuff. So I do apologise if some of it is repetitive for some, or for some it's a bit too beyond them. But in terms of just describing where we're at in myeloma, it does require sort of covering a bit of old ground, and then also just using a lot of long names that end in ab and ib, so I apologise with that, but you'll hopefully get an idea of things as we go along. So a bit of a pop quiz to start. Does anyone know who this is? Yeah. Do you know the name of the actor, anyone? Yeah, Roy Schneider is his name. So yes, this is of course a scene from Jaws. Everyone can see a very definitive horizon in the background there too, just by the by. Does anyone know what Roy Schneider died of? Yeah, there you go. There. Roy was diagnosed with myeloma in 2004, and as with most patients, within 6 months had a autologous hematopoietic stem cell transplant, and gained a partial remission, but unfortunately his disease relapsed and he died of complications, I believe, with a staph infection in 2008. But unfortunately, Roy's path is really typical of where the outlook was for people even looking only 9 years ago, in that one would suggest that someone had a prognosis of around 3 years or so without a transplant, and maybe extending that by 5 years with the transplant. I don't know exactly what agents Roy was given, as most sort of Hollywood stars probably got the biggest and best and went to cancer centre in University of Arkansas, I believe. But his picture really unfortunately typifies where myeloma was at less than a decade ago, but things thankfully are changing a bit. But one of the does anyone remember one of the more famous lines from Jaws that Roy Schneider is famous for? Something to do with a boat. Yeah, going to need a bigger boat. So that's right. You're going to need a bigger boat, and I think that's where we're at with myeloma. Thankfully, we do have a bigger boat, bigger than the one you can see that got virtually destroyed by Jaws the shark there. But now we're carrying a lot more around in this bigger boat, all these agents, as I said, that end in ide, ib and ab, and which I'll go into a bit more detail to help us fight the fight against myeloma. So just to review the basics for those here. So myeloma, or multiple myeloma, or by strict definition by the World Health Organization, should be called plasma cell myeloma. In talking to my very learned colleague Devinder Gill, he says, why do we say plasma cell myeloma? Because there's no other type of myeloma. Well, it's just to help classify really what the cell is that goes wrong in myeloma. And it is a cancer of the plasma cells. So about 1,200 Australians per year will be diagnosed with myeloma. In the US, it's about 20,000 per year. Plasma cells are a type of white cell. They're in fact lymphocytes that have gone the next step in making immunoglobulins. These are the proteins that protect us usually from infection. So if we've had measles, chickenpox as a kid, we'll keep producing these immunoglobulins, particularly ones called IgG, which keep us out of trouble for the future. In the setting of myeloma, these plasma cells proliferate, build up and go unchecked and keep making immunoglobulins, which is how we usually end up picking it up in the blood, either by way of what we call a monoclonal band or M-band, and in some diseases it's a thing called the free light chains or serum free light chains, which is a fragment of the immunoglobulin protein which we can pick up, and they're generally ones that are passed in the urine and historically used to be called Bence-Jones proteins. So, I, even as a med student, always found myeloma as a very difficult type of cancer to understand. I always find it difficult describing to patients and their relatives about it, in that you're not talking about a single lump. You're not talking about cells that fill up the blood, because they usually confine themselves to the bone marrow, but we're talking about a type of immune cell which is usually at very low numbers in the bone marrow that decides to proliferate and throws these proteins out into the blood, which then go on and cause havoc elsewhere. Particularly the kidneys get deposited with these proteins and affect their function. So the kidneys are the organ that gets rid of urine in our body and gets rid of the nitrogen waste, and then also they causes havoc with the bones, because the plasma cells release this thing that they've discovered called rank ligand, and the rank ligand is a thing that sets off the cells that eat away our bone, which is a normal turnover process. As we get older, all our bone gets replaced, but the osteoclasts, which are the cells that break down our bone, are just put into overdrive. They weaken the bone, cause an osteoporosis type picture. They throw calcium out into the blood, and high calcium makes you sick alone. It can make you confused, form stones throughout the body, like in the kidney tract and stuff. So the effects not only of the tumour cells building up in the bone marrow are there, which I'll just get to, but it also weakens the architectural part of the bone which holds us up. So the myeloma cells, or the plasma cells that build up there, can then stop the red cells that make us, that carry oxygen around, that keeps us going, and you can get anemic. It can affect the platelets, or what we call thrombocytopenia, and they can drop and you can be more prone to bleeding. It can also cause leukopenia, which is low white cells, and make you more prone to infections, particularly the white cells and neutrophils are the ones which, if dropped, will make you more prone to infection. Additionally, very high levels of protein can interfere with the clotting system, which is reliant on proteins, and interferes with them. So people presenting with myeloma with excessive bruising and bleeding may not only be due to platelets, but with interfering with what we call the coagulation system. When we're considering myeloma and whether it's affecting someone, we used to call it smouldering myeloma or asymptomatic myeloma, where people had plasma cells in their bone marrows, had a protein in their blood, but they didn't have anything else going on. We now term it asymptomatic myeloma, the A meaning without symptom myeloma. And for those people that have symptoms, though, either feeling unwell, lethargy, tiredness, or any of the things I've described before, we mainly look at a thing called the CRAB criteria, which it took me until I think I was doing my general physician training, and no one taught me this at med school, but I've always found a very, very useful acronym to know how serious myeloma is. So if you have a raised calcium, then that is a disease criteria that fits with symptomatic myeloma. If you have kidney damage or renal damage, that's what the R stands for. If you have anemia, so your red cells are low, generally down to a level below about 110, where about 120 to 170 is normal. And if the bones are affected, so if there are spots in the bones or lytic lesions where the bone have been eaten away, or you've become osteoporotic because of that process, or had a fracture that's occurred, a break in the bone, which doesn't fit with normal trauma like falling over or having a landing from a big jump or something like that. So the CRAB criteria of myeloma is vital in saying that the disease is symptomatic and causing problems. Now these are the bad cells here, these ones that have what we call an eccentric nucleus. This is where all the DNA is stored, and this stuff here is where all the immunoglobulins is stored, and down a microscope they look very blue, and so there's way too many of them. There are other normal bone marrow cells there, but all these ones here are the plasma cells, and some of them have a lot of protein building up in them there. So I talked about lytic lesions, so this is where plasma cells are built up, and sometimes we call them plasmacytomas, or a lump of plasma cells. Sometimes we call them microplasmacytomas, or small lumps of plasma cells. And they can occur all through the skeleton, but the skull's a very easy place for even a lay person to pick out that this skull should be all this sort of whitish colour throughout, and then you have these dark spots here through the skulls, and this is a picture showing some quite large ones at the back as well as multiple small ones. So the idea of multiple myeloma is very easy to get a hold of. Is saying you're talking about multiple little spots through the skeleton like that. And we see the same thing when we do a bone marrow test, which is a vital part of diagnosing myeloma, and that's what those plasma cells in that previous picture were taken. You take a little chunk of bone, you see these spots and collections through even just a 1 to 2 millimetre wide chunk of bone. It's usually about 20 millimetres long, and we can see this sort of multiple spot kind of a pattern that occurs in multiple myeloma. This is a bit more of a scientific diagram, but it just shows that the myeloma cells, which that's a cartoon of them, but that's kind of what they look like down the microscope, secretes this stuff called rank ligand, and these are the cells that go and eat away the bone. It's the eating away of the bone that historically, even less than 100 years ago when we hardly had anything to treat this disease, was so crippling that this just ate away at the bones. People had crushed sternums, they had crushed backs, bent over, legs and pelvis broke underneath them because of this process of eating away at the bone. And I think the disability that was due to that in the past is kind of lost on people. Now we have drugs that fight this pathway and act against the tumour as well. So I've sourced this from a journal which I thought was an excellent representation of where the natural history of myeloma goes, and hopefully this end bit will change quite a bit, or at least these times in between treatments will stretch out a bit. They have put crosses there because they're not limited to as represented on that chart, but generally most patients will have had a protein in their blood, but because it may not be extremely high, it probably won't be picked up with the general blood tests that are done with a GP. Now I must say, it's a very common question when we find this abnormal protein and say, well, I've been getting blood tests from my GP every year, they've never picked up anything wrong. It wasn't until I got anemic or got some numbness in my feet or broke this bone that they found this was wrong. So the level of this protein may only be at a relatively low level of about 10 to 20 grams per litre, and that may not pick up on a general blood test until you ask for a thing called serum electrophoresis. So undoubtedly everyone that's diagnosed with myeloma may have at one stage, it may have only been a short stage, have had just the protein detectable in the blood before it got high enough to start to cause problems through the bone marrow and the skeleton. Not all people that have this thing, smouldering myeloma, as I said, it's historically called, or MGUS turn into myeloma, turn into symptomatic myeloma or active myeloma. But we see a far greater number of people that have this thing called MGUS. I'm not going to confuse you with big long names, but this is a thing called monoclonal gammopathy of undetermined significance, which just means the protein is there, but there's not, again, any signs of myeloma, and that it's usually at a fairly low level. And MGUS has a rate of only about 1 to 2% per year, turning into myeloma that would require treatment. Anyhow, at some point, and this may be the point of diagnosis, that active myeloma is found, and at that stage we go in with first-line therapy, and usually one will get a most significant response with the first line of treatment, have a period of remission, and then there will be relapse, and as things go on, the disease tends to get harder and harder to treat. Thankfully, the number of relapses and the ability to treat is getting further out. We have third, fourth line options now. Hopefully, as I said, that this distance is widening, but ultimately and unfortunately, myeloma remains incurable. People may have complete remission where we don't find any evidence of the disease after a treatment course, but inevitably it comes back. Now, there are exceptions, and there are people that have had autologous transplants and it goes away, and they may be 10 or 15 years down the track, but they are rare, or even having transplant of stem cells from another person called allogeneic transplant. But by and large, myeloma remains incurable, and certainly in terms of the research and development in myeloma, having a curable disease is what we would like to see for the future.